All right, everybody. So we are going to hit up another one of the big five, and it's general physiology. So with general physiology, there's going to be about 42 to 45 questions, which is quite a few. And so we're going to go through, talk about some things, especially hormones, muscles, pretty in depth. And along the way, we're going to have lots of illustrations just to kind of help you out with some of the physiology pictures so that you can nail it for your exam, okay? So we're going to start with just some very basic physiology or cellular function. So you guys have all had this several times before, but let's just go big picture, all right? So we're going to talk about intracellular and extracellular components, and check out this visual and draw it along in the side of your margin just so that you can have a good understanding of what we're going to talk about. All right, so let's draw a cell. Now, if we talk about the intracellular compartment, this, I want you just to write water inside because it consists mostly of water. Now, it's separated from the extracellular compartment just by that cellular membrane, and inside are all the intracellular organelles. The main electrolyte, and what I want you to guys is to write potassium, K+, right inside. The other thing I want you guys to remember is that inside the cell, this is an acidic environment. So write the word acidic. Now, the extracellular compartment is obviously the environment outside the cell. Now, this is composed of blood plasma and interstitial fluid. The main electrolyte out here is sodium. Now, if we look at membrane potential, that is basically a function of both electrical and chemical gradients. Now, we already talked about the fact that potassium inside the cell is greater than outside. So this is going to help set up our equilibrium potential. Now, the potential of most cells is minus 90 millivolts in the cell. That is something else that I would have you draw on your picture here to finalize their cellular function. That's just the big picture of what a cell is. Now, let's keep going. I want to go down to transport mechanisms. So a couple just key things here that I would know is when we talk about cellular transport, it can go two ways, uphill or downhill, okay? Uphill, highlight that requires energy. So that first bullet point, highlight it needs ATP, okay? Downhill does not need energy. So highlight that. It's a couple lines down after downhill, not require energy, and there's two types, okay? There's simple, so non-electrolytes diffuse across the membrane, and there's carrier-mediated transport, okay? Highlight here facilitated diffusion. I would know that facilitated diffusion is an example of carrier-mediated transport, okay? So I also put a paragraph there, and it talks in that paragraph about some transport maximums. We're going to talk about that more in renal physiology. So just read through that passage just to kind of understand it, and we'll talk more about that later. So now we can talk about some membrane receptor and events. I just put here the different types of receptors, just peruse through them. Go down to nicotinic receptors because those are a little different. Nicotinic receptors in that box, as you can see there, they're unique in that they open sodium and potassium channels. Highlight that. That's kind of the big picture I would know as well. All right, let's keep going. Let's go down to body fluids. So again, just big picture concept stuff here. I would know that intracellular compartment, again, what did we say it was? Right, potassium. Extracellular, what? We have interstitial fluid and plasma. Okay, I would know the amount of fluid here too. When we think of interstitial compartments, that is about 25 liters. So most of the fluid is found in the intracellular compartment, okay? In the extracellular, interstitial fluid is about 12 liters, plasma is 3 liters. So I would just make sure that you know about fluid concentration there or fluid amount there. Otherwise, water, 60% of our body is composed of water, and that's in the box. So let's keep perusing down. We have diffusion, simple diffusion. Just go ahead and read through that. We're going to talk about more of that when it comes to different body systems, so just make sure that you're aware of those definitions. And let's start going down into some heavier physiology, starting with the lungs. Let's just first go through a little lung anatomy. So remember, the lung has different lobes. So on the left side, there's 2 lobes because you need to make room for the heart. On the right side, there's 3 lobes. It has a middle lobe lung space, okay? Just surface anatomy there. When we talk about each lung, it has different surfaces. You can read through that. Each lung also then has two zones, okay? We have our conducting zone, which is our upper airways and our trachea. It's the place where air finally kind of meets water in our body. And then we have the respiratory zones, which are bronchioles, our alveolar ducts, and our sacs. This is where oxygen is going to take place being dissolved, okay? So we need to talk first about the mechanics of breathing. So when we think about the mechanics of breathing, we obviously have inspiration and expiration. Inspiration, I want you to highlight active. It's an active process. It needs muscles. So highlight there under that first bullet point, it's the diaphragm. The diaphragm contracts. Second bullet point, our external intercostals contract. And then third bullet point, scalenes. That's a little anatomy, but we need to know those three big muscle groups in terms of how we use muscles for our inspiration. Now, the beautiful thing about our lungs is that once we take the energy to take in big air, it's like a balloon and they just deflate on their own. So expiration, highlight passive process. The diaphragm relaxes, everything relaxes. You can forcefully push out air. And when that happens, then you can have muscle movement there, but otherwise we just breathe out. Again, expiration, highlight passive, okay? All right, look at that box there. There's a box, and we're gonna kind of get into some disease here, but it says loss of lung elasticity leads to an increase in lung compliance, all right? What does that mean? Well, let's talk about like if you have hyperinflation of the lung. Hyperinflation of the lung, that means that your lung is stretched out too far, almost like a stretched out sock. It just doesn't quite fit as well. An example of this then is emphysema. Remember in pathology, we talked about emphysema and they have all these oxygen molecules stuck in there that they can't get out. Those lungs are in hyperventilation state. So they have loss of elasticity and therefore they can't move air as well. All right, I would be aware that emphysema has a loss of lung elasticity. Okay, let's move on. So again, remember when we talked about forced expiration, how we use muscles? I would know that those are the internal intercostal muscles. That's the next bullet point, just highlight it, okay? So we can graph out all of our inspiratory and expiratory motions on something that we call a spirograph. And this is really helpful in medicine to determine somebody's lung disease states. So we have emphysema, we have bronchitis, just to see how bad that these patients are. So let's take a look at it. So let's take a look at the spirogram. So on the spirogram, you can see that there's different wavelengths for each expiratory and inspiratory process. Look at that TV or tidal volume. That is just your normal inspiration, expiration as you're sitting here listening to this video. Then we have all of these different ones that we can either directly measure or indirectly measure to determine a patient's disease process. You can go ahead and read through the different direct measurements and correlate them with this picture on the slide and pause the video. Otherwise, we can jump right over and go to the indirect lung volume measurement. Take a look at that residual volume. Residual volume is basically the air that no matter how hard we try to get out of your body, it will stay. So we can measure residual volume by taking the functional residual capacity minus the expiratory reserve. So let's put this into a clinical example. So if a patient has emphysema, for example, then this patient is going to have a high residual volume, correct? Because we know that they are holding air that they cannot breathe out. So therefore, their RV is going to be higher. Also then, their functional residual capacity will be higher as well. This has been a question that they've hit in the past, so I would be aware of residual volume, expiratory volume, and make sure you know total lung capacity. Total lung capacity, remember, is the entire volume of the lung that exchanges gas. So total lung capacity equals vital capacity plus that residual volume that we just solved for in our emphysema patient case. One other thing I will mention here is forced expiratory volume. The FEV is often measured on how hard somebody can blow out their air over 1 second. We can compare that to the functional vital capacity to determine the respiratory function of a patient. And then we can classify lung disease as either restrictive or obstructive. So we've already talked about COPD being an obstructive disease, right? And emphysema and bronchitis in that. And now we just need to talk a little bit more about restrictive diseases. So if you look at that box there, it talks again about restrictive diseases, and it's characterized by poor expansion of the lungs with a decrease in lung volume. But their FEV1 over FVC ratio will be normal to slightly elevated. I would remember that point. It's just in that box there, okay? You can also read through the rest of that anatomy there with the dead space. I think that's very low yield. What isn't as low yield is when we start talking about oxygen and carbon dioxide and the mechanics of breathing. So let's check that out. So once we start talking about oxygen and carbon dioxide, we need just to remember a few key points. So oxygen, I would highlight that first bullet point where it says 98% of oxygen is bound in hemoglobin. And remember, hemoglobin is a protein with those 4 peptide subunits. The more oxygen on each subunit, the more oxygen partial pressure there is. And we're going to talk about that in a little bit, okay? The remaining 2% of that is dissolved in plasma. Now carbon dioxide. So carbon dioxide, I want you to know, is 20 times more prevalent in the body than oxygen. So we also need to highlight that. It's an important point. Look at that number 1. It says 90% of carbon dioxide is transported to the lungs in the form of bicarbonate. And this is where we start talking about carbonic anhydrase, because carbonic anhydrase is used within red blood cells to catalyze the first step of a really important reaction. And I'm going to show you the reaction here on the board. So look at this reaction here, and I would know this. So it says that carbon dioxide plus water gives you H2CO3, all right? H2CO3 is carbonic acid. So what happens then is carbonic acid is broken down into HCO3, which is bicarbonate, as well as an extra hydrogen ion. That's what role carbonic anhydrase has within this equation. Do you guys know where carbonic anhydrase is used? The proximal convoluted tubule, and we'll talk about that in a minute. So when we talk about breathing in O2 and breathing out CO2, we need to talk a little bit about the atmospheric pressure as well as what happens to the partial pressure of those gases in the body. So if you think about the air we breathe, it has an atmospheric pressure, and you can see it right there, of 760 millimeters of mercury. 21% of that is O2, okay? As air enters the trachea, O2 starts to dissolve. And I put a picture of this in the book, and I'm going to put it up here on the screen too. So let's talk through it. So take a look at this picture. So if you see here, air coming into the body has a partial oxygen pressure of 160, all right? Very low carbon dioxide, it's at 0.3. When it gets to the alveoli, the partial pressure of oxygen starts to decrease. It's about 104, but look at the arteries. The partial pressure of oxygen is 100. So if they ask a question on the test, what area of the body has a partial pressure about equal to the arteries? The answer would be the alveoli. But let's go through here. So now we're going through the body and we're dumping oxygen to those tissues and cells that need it most. And then check out the veins. Look at the veins, and that the partial pressure of oxygen is less than 40. So much less, obviously, than in the arteries or the alveoli. So if they ask you a question on the test asking where the partial pressure of oxygen is the lowest, the answer would obviously be the veins. So diffusion rates of oxygen and carbon dioxide can differ too, and so we need to talk a little bit about that. So there's 4 things I want you to know. The first thing that can affect the diffusion rate is the thickness of the membrane, and there's something called Fick's law, which says that the diffusion rate is inversely proportional to the thickness of the membrane. I would know that, all right? Next is surface area. Surface area is directly proportional to how fast that the gas can diffuse, okay? The diffusion coefficient of the gas is also important, and I would just look at that second bullet point there and remember that carbon dioxide is approximately 20 times more soluble than oxygen. Highlight that. And then the last one is partial pressure differences. Gas will always flow from an area of high pressure to low pressure, so keep that in mind, all right? So now we're going to move on to another big concept, which is also important to know, and that's the oxygen dissociation curve. So the oxygen dissociation curve is basically telling us the oxygen carrying capacity in the blood, all right? So let's go ahead. I'm going to put up a partial pressure curve so you can take a look at it. So if you look here, on the x-axis we have the partial pressure of oxygen, and then on the y-axis we have hemoglobin saturation, all right? So when the partial pressure of oxygen is high in the tissues, hemoglobin can more readily bind to oxygen, so there's more hemoglobin saturation. When the partial pressure of oxygen is low, it can't hold on to as much oxygen. That's what gives us our partial pressure curve that is in that sigmoid shape. When the partial pressure is 50 in the arterial oxygen, hemoglobin will be half saturated. The behavior of this graph is really important because different disease states makes it move to the right or to the left. So if you think about it, if there is a shift to the right, what is that telling us? Well, a shift towards the right indicates that the hemoglobin is less capable of binding to oxygen at a given partial pressure. All right, so what are some things that can cause that? Well, let's list them off here. A decrease in pH, so higher acidity, makes it harder for the body to put oxygens on the hemoglobin. An increase in temperature and an increase in CO2 levels. And remember, an increase in CO2 levels still makes it more acidic, again, causing hemoglobin to not be able to maintain as much oxygen. So what about some clinical examples of this? Well, clinical examples would include exercise, congestive heart failure, anemia, lung disease, and kiddos. All of those things naturally will make this curve shift to the right. Again, what is that telling us? That it takes more work to get oxygen to bind to the hemoglobin. Now, what happens when we shift that curve to the left? When we shift the curve to the left, basically that makes it easier. It makes that hemoglobin more readily able to bind to oxygen at a given pressure. Less work to saturate that hemoglobin. So things that cause this: higher pH, so basic environments, lower temperature, and reduced CO2 levels. I think that is all very important to know for your exam. And then there's one gas that we didn't really talk about, but I put in the box here, and it's definitely worth knowing. And that's about carbon monoxide. Carbon monoxide really loves to bind tightly to that hemoglobin. And when that happens, then oxygen can't bind. So a couple things I would know, again, that first bullet point right there, it says that it binds more readily. And two, once it's bound, it's hard to come off and oxygen cannot bind. And so you're carrying the carbon monoxide around in the bloodstream. Okay? All right, so let's talk about the regulation of respiration. So for neural control, what I want you guys to highlight is just that first sentence there where it talks about the rhythmicity center is in the medulla oblongata, all right? The medulla oblongata also does different things like cardiac things, vasomotor, vomiting, all those things, okay? But rhythmicity center, think medulla oblongata, all right? What happens here is you have these aponistic centers in the pons, which send signals to the medulla oblongata, all right? If you look at that second bullet point down, look at the activation of pulmonary stretch receptors in the bronchioles. That leads to also negative inhibition, okay? So what that means is that it can't overflate, all right? So that's kind of our negative feedback so that we don't overflate our lungs. And that's also part of the neural control. Also, the frontal cortex or our cerebral cortex also helps us control breathing. Like we can purposefully make ourselves breathe in and breathe out. So that would be an example of neural control as well. All right. If you also go then to chemical control, this is a little bit different. So neural control was neurons that control our respiratory movements. Here, the peripheral control is all about the concentration of carbon dioxide and oxygen in our body and making sure that the feedback in how we breathe is appropriate. So let's take a look at number one. Let's look at those peripheral chemoreceptors in the carotid and aortic bodies, all right? These are located in the walls of the carotid and aorta, and they measure O2 and CO2 levels in the bloodstream. This is important because if we have an increase in CO2, then we know that the serum is acidic. Our blood is acidic. So what does that mean? Well, that means that we need to breathe off CO2 or intake more oxygen. And we're going to talk a lot about that in a few minutes, all right? Those are your peripheral chemoreceptors. Now, your central receptors are in the medullary chemoreceptive neurons. So again, in the medullary center, okay? And this is important because what does this look at? Well, it also looks at oxygen, carbon dioxide. Hydrogen ions, remember, they can't cross the blood-brain barrier. So hydrogen ions in the blood can't tell us if we have an acidic system or not. But carbon dioxide can, and these are extremely potent to changes in carbon dioxide levels. So for example, if our body notices a change in the partial pressure of carbon dioxide from like 40 to 44, it causes respiration to double. And remember, anytime that we have an increase in acid or a decrease in pH, remember, same thing, that causes our body to increase the rate of respiration. And that's basically what that box is telling you right there too. So I would make sure you know this, the increased acid we have in our body, the increased rate of respiration. And that's going to be super important when we start talking about our acid-base balances. So let's continue. Let's start with respiratory acidosis. So if we look at respiratory acidosis, respiratory means it's either being caused by hyper or hypoventilation. Acidosis means that we have a decreased pH, right? So what is that being caused by? It's caused by hypoventilation. Hypoventilation causes an increase in dissolved carbon dioxide, which then decreases the pH, okay? In terms of how do we conquer that, or how does our body get over that? Well, it's our kidneys' job to kick in. And what's going to happen here is the kidneys compensate by decreasing how much bicarb they're peeing out in the urine. Instead, it's going to put the bicarb back in the bloodstream to help neutralize that pH, okay? All right, let's go to the next one. Respiratory alkalosis. So again, respiratory, think, okay, it's my lungs' fault. So are you hyperventilating or hypoventilating? Right, you're hyperventilating, okay? So here, if you're hyperventilating, you have too much oxygen dissolved in the blood, making the pH goes up, or you have an alkaline environment, all right? So what's your kidneys gonna do here? Right, they are gonna pee out bicarb so that you can have a more acidic system for your alkaline environment to make it more neutral, all right? The other thing is here is you see those people when they're hyperventilating and they start like blowing into the paper sack. Well, why are they doing that? Well, the whole purpose is if you're breathing so fast, you're blowing into the bag, you're blowing out carbon dioxide and then you're breathing carbon dioxide back in, which makes it so that you can make that alkaline state more acidic if you're breathing back in carbon dioxide and not oxygen, hopefully slowing down your ventilation as well, okay? All right, you can just go ahead and look at the symptoms of hyperventilation, hypoventilation. It's in the box. I would take a look at that. All right, now let's switch gears and think about metabolic acidosis and alkalosis. So metabolic, okay, so this is something our body's doing. This isn't dealing with how fast we're breathing at the time. That's not causing this. So let's look at metabolic acidosis. Okay, so let's think about this. If our body is at an acidotic state, we have a decreased pH. So what can cause that? Well, a couple things. First of all, it's due to diarrhea, okay? So if we have lots of diarrhea, we have lots of bicarb leaving our system, and that can put us in an acidotic state. We've talked about ketoacidosis, like in pathology with our diabetes. That, when we break down ketones, makes us to have a more acid state, so that can cause metabolic acidosis. Also, fasting can cause metabolic acidosis. So think of those things. So how do we compensate for that? Well, it's our respiratory's job to do that, okay? So if we are breathing, our natural breathing level is going to cause an increase in ventilation. Because remember we said the lower the pH, the more C2, the faster we're going to breathe to try to breathe in more O2, okay? So we'll have an increase in ventilation. Also, the kidneys can kick in too by excreting more hydrogen ions in the urine. All right. Let's do the opposite now. Let's talk about metabolic alkalosis. So again, our system isn't right because what? We have too much bicarb. And usually this is due to vomiting. And when we vomit, we lose a lot of hydrogen ions. So that's the main cause here. But our lungs are going to kick in too, and our respiratory rate is going to change. So here, are we going to increase or decrease ventilation? Right, we're going to have a decrease in ventilation, which is going to increase the amount of CO2, which is going to help increase our acid levels, which will help stabilize the pH in the bloodstream. All right, Those are big concepts. They're important. I would just make sure that you break them down and make sure that you understand them, know the cause and the effect in some disease states for both. All right, good job.